Thank you so much for inviting me. Mm. So here you can see you're having myeloid lineage, you're having lymphoid lineage. We discussed the entire blast. Now we discussed the B cells, the smart cells, the plasma cells. We discussed the T cells, CD4, skin problems. Now we are discussing the mature lineage of your myeloid stem cell. So the first one is going to be your granulocyte, that is neutrophil, basophil, eosinophil. They are the mature cells of your myeloid lineage. So whenever they get cancer, that's going to be a chronic one, right? We're going to name them, but the names are really different, a little bit different, right? But the chronic is the main hallmark for cancer of your mature cell. Just keep that in mind. So the first one is chronic myeloid leukemia. We get cancer of mature cells since it's the name suggests chronic. So it means it's basically a cancer of mature myeloid lineage cells. So what are those cells? What are those mature cells? Those are your basophils, your eosinophils and your granulocytes in the end, right? But the more dominant cells which you are going to see in this cancer are your basophils. Really important. Basophils are going to be the hallmark of this cancer. Like among those granulocyte, basophils are going to be really more, right? Really high. So it's basically associated with 922 translocation, also called as Philadelphia chromosome. So what happens in Philadelphia chromosome? That's really easy. We are going to be having fusion of BCR and ABL. Keep that in mind. Just memorize it. But what's the concept? As we have fusion of this BCR and ABL, it would increase the tyrosine activity in the cell. So as the tyrosine activity increases, we know what is tyrosine kinase. It's basically, you can just simply, like it's a second messenger system, right? So you will be sending more messages to the cell to make, a lot of cells, a lot of granulocyte. So if I'm just sending a lot of messages, a lot of stimulus to the cell to make a lot of, you know, these cells of your myeloid lineage, the granulocyte. So obviously, in the end, that's going to lead to a cancer condition, right? So it's going to be due to 922 translocation, really important, really high yield. BCR ABL fusion, really important. And as we have fusion of BCR and ABL, it would lead to increased tyrosine kinase activity. And this increased tyrosine kinase activity is going to lead to overproduction of these cells, especially the basophils. Keep that in mind. So the first line treatment is going to be imatinib. And what does imatinib do? It blocks tyrosine kinase activity. So if you are blocking the tyrosine kinase activity, it means we are helping this condition because the main cause of this cancer was increased tyrosine kinase activity. So that's all. Increased tyrosine kinase activity. Why? Due to 922 translocation, Philadelphia chromosome, BCR, ABL. Just memorize it, okay? Okay, so we are going to have splenomegaly. Okay, along with that, we can have accelerated phase of disease transformation. Okay, remember one thing, they have just marked that it can transform to AML or ALL. You can see, although it's a problem with, okay, it's problem or cancer going on here in these cells, right? But they're just telling you can just transform into ALL. How? How? What do you guys? Actually, the problem here is genetic, right? You can see it's a genetic problem, which is going to be present in hematopoietic stem cell. Because, genetic problem is going to be present in your parents that are your hematopoietic stem cell, right? And then if you have 922 translocation, then we can have this condition. So since it's a problem with this parent hematopoietic CD34 stem cell, so it can go either way. Either it can just get into the AML or either it can just get into the ALL, right? Because it's a problem with the parent, genetical problems, so it can move either way to AML or ALL, right? That's the important thing which you have to remember. So now you have to differentiate CML from leukemoid reaction. So what is leukemoid reaction? It's a common kind of infection. Whenever you have any kind of infection, the granulocyte count would increase again. And in this cancer, again, the granulocyte count increase. So now the question arises that how would we differentiate whether it's a cancerous condition or whether it's due to a leukemoid reaction? So first of all, we are going to look for something called leukocyte alkaline phosphatase, LAP, LAP, right? That's basically going to be present within the granulocyte. So in leukemoid reaction, we'll be having LAP, while in CML, we won't be having LAP. Really important, right? Leukocyte alkaline phosphatase. Since CML is a cancerous form, everything is going to be really disorganized there. And since we do not have any infection going on there, it's a cancerous condition, so we won't be having LAP. Or in case of any kind of infection, the LAP is going to be early. And as I already told you that in CML, as compared to other granulocyte, the basophil levels are going to be more. So if you just compare it with leukomoid reaction, CML with leukomoid, so the basophil count is going to be more in CML, while you won't see basophils in leukomoid reaction. Okay, and then you can just do look for some genetics. What's the problem going on? So obviously you are going to have 922 translocation in the CML and no mutation or no translocation in the leukomoid reaction. So that was all about our chronic myeloid leukemia. Okay,
Um,
so we discussed the mature form. Yes, please.
what does leukemoid reaction mean?
Leukomoid reaction is basically, any kind of infectious. Like for example, if we get infection, right? Infection. So as a result of that infection, bugs are entering. You're going to be having granulocytes in order to fight them off. For example, if it's a parasitic infection, you need eosinophils there, right? So it's our normal, leukemia-like reaction, right? So it's just leukemoid leukemia-like, but mostly it's going to be seen against an infections, right? Infection, the leukemoid reaction is going to be seen. Okay, is it clear?
Yes.
Okay. So, so we discussed that the myeloid lineage, you can see it here. Okay, the myeloblasts we discussed. Now let's come towards our erythroblast red blood cells, right? So we are now in the mature category. We know that, right? Okay. So in the mature category, let's just come for red blood cell, right? So whenever we have a lot of red blood cells, we know that condition is known as polycythemia. Right? Whenever the hematocrit increases, you might have already have an idea what is polycythemia. But there are different, causes or variants of polycythemia. The one which we are going to start here is polycythemia vera. What is polycythemia vera? Again, it is polycythemia. We are going to be having a lot of red blood cells. The hematocrit is going to increase a lot. So that's a polycythemia. But vera here means that it's going to be due to genetic problem, associated with JAK2 kinase mutation. If you have JAK state or JAK2 kinase mutation, again you are sending a lot of signals to the cell. It's a signaling pathway to make a lot of red blood cells for me. So if you have mutation there, you're going to be having a lot of red blood cells, and that's going to lead to polycythemia. So let me just ask you a question. What will happen to the erythropoietin level in polycythemia vera? Increase or decrease? What do you guys think?
In primary, it's
You will
decreased.
It's
In
decrease.
secondary,
increased.
it's increased.
In polycythemia vera,
It is not going to
Increase.
increase.
Decreased.
It will increase.
increase?
Increase.
No, decrease in
No,
primary
no, no,
decrease
No,
no.
and
it
in
is going to
Okay,
decrease
just
because
please
In
just keep
primary,
silent.
it's
because there is
decreased.
in
mutation.
secondary there will be exogenous some type.
Okay, I need a single answer.
Erythropoietin is decreased in polycythemia vera.
Yes. Okay, so the erythropoietin level is going to be decreased, right? Because we have a lot of, hemoglobin that's going to lead to decreased erythropoietin level, right? So in polycythemia vera, how to diagnose it via labs? Increase hematocrit with decreased EPO. For example, if we just name the condition in which the erythropoietin is high and we have polycythemia there. In which condition I'm going
Renal
to
cell
see it?
carcinoma.
Secondary.
Yeah,
COPD.
renal cell carcinoma.
Renal cell carcinoma and this, chronic hypoxic like COPD and emphysema.
Oh, okay, perfect. Hypoxia, right? So in hypoxic situations or in the renal cell carcinoma, what else carcinoma can give us a lot of?
Also, Budd-Chiari syndrome.
Mhm. Okay. What else? Okay. Okay. So we'll just discuss that in a while, okay? So J2 kinase mutation, so we have a lot of red blood cells. If we have a lot of red blood cells, the blood is going to become really viscous because it's going to be, really dense spread with those, red blood cells. So it's going to lead to this hyperviscosity of blood. We are going to be having blurry vision and headache. Simply you can think of if the blood is really viscous, it would be really hard for the blood to pass through those, arteries because it's really viscous, moving very slowly. It can lead to venous thrombosis as well because we have viscous blood. It can just lead to coagulation cascade activation. We are going to be having flushed face, itching, especially after bathing. Really important, right? So individuals with polycythemia, whenever he bath, he's going to be having histamine release from the mast cell, which is going to cause a lot of itching. Really important, really important. Okay. So for that, we have to give phlebotomy and hydroxyurea. So you know, hydroxyurea is an anti-DNA kind of drug. We are going to discuss that in our oncology, right? So it would just stop the DNA formation, and it won't let overproduction of these red blood cells. And phlebotomy just removes some blood, right? Okay, so here you guys can see that polycythemia vera, erythropoietin are increased. And what would vera normal or abnormal? Saturation of oxygen. Hello? In
Sorry,
polycythemia
your
vera.
voice was breaking, sir.
Your voice was breaking.
It should be normal.
Hello? Can you hear? Can you guys hear me
Yes, sir.
well
Now
now?
okay.
Hello?
Yes.
Can you
Okay,
repeat the
perfect.
question?
Okay, my question is: we have an individual. He have normal. Okay, he have okay, let me just give you another case. We have an individual with normal oxygen but really high erythropoietin and high hematocrit. What should be your diagnosis?
He's taking exogenous
Yes,
erythropoietin
yeah, exogenous
or
or
with the malignancy
RCC.
Bodybuilder, yes.
like RCC or the HCC, which are producing the erythropoietin factor.
Okay, perfect, perfect. So exogenous, or either it can be due to a cancer, right? Renal
Yeah,
cell
renal
carcinoma,
cell carcinoma.
Renal
right?
cell.
Renal cell carcinoma. Perfect. So in polycythemia vera, the EPO is going to be decreased while the SA or the oxygen saturation is going to be normal. In the reactive polycythemia, we are going to be having hypoxia, which is triggering the release of EPO, and EPO further would lead to polycythemia, right? Hello? That's a
Yes. Yes, sir.
okay, due to due to hypoxia, right? And the other which we discussed, that if you have normal concentration of SaO2 or partial pressure of your oxygen with increased EPO and increased hematocrit, so that's going to be due to some malignancy or exogenous agent. Okay. So let's discuss our next topic, that is essential thrombocythemia. So again, we are just discussing these these mature cells, right? So we discuss if you have cancer of this mature one, so chronic myelogenous for the red blood cell, that was polycythemia vera. Now let's just come towards our megakaryocytes and platelets. Platelets are more mature than megakaryocyte, right? So if we have, let's suppose, any condition which is leading to any cancer of platelets, we are having a lot of platelets, so that's essential thrombocythemia, right? So neoplastic proliferation of mature myeloid cell, especially platelets. Remember, all of these lineages are, if they are neoplastic, whenever we have JX kinase mutation, so we are going to be having increase in this entire lineage of these mature cells of your myeloid, right? But it depends upon that which one are more as compared to the other, right? So if if you have jack state mutation, your red blood cells are also going to be high, platelets are also going to be high, but now you have to look as which one are more higher. So the more higher, that's going to be the pathology, right? So again, if you have the same jack state mutation and this time you have increased platelets, so there's going to be essential thrombocythemia, right? So if you have essential thrombocythemia, so what happens as a result of that? What would be the symptoms? High risk of bleeding or thrombosis. We know that. Okay. We are going to be having myelofibrosis, which we'll be discussing in a while, right? And we have no risk of hyperuricemia or gout, because we discussed that the megakaryocytes do not contain any DNA, do not contain any nucleus, do not contain any purines. So you won't make any uric acid, because uric acid comes from your urine metabolism, right? Or perfect. Myelofibrosis. What is myelofibrosis? It's basically neoplastic proliferation of megakaryocytes. So we discussed, you can see it here, that we have megakaryoblast, then megakaryocytes, and then megakaryocytes are going to give you platelets. We discussed the platelets, right? Let's just discuss cancer of megakaryocytes. So whenever we have a neoplastic proliferation of megakaryocytes, what would happen as a result of that? We'll be having, again, it's going to be due to JAK2 kinase mutation, as you mentioned, right? So these sites are going a lot of platelets derived growth factors. And we know the function of platelets derived growth factor, it would lead to fibrosis. It would lead to fibrosis of the bone marrow. So it will be having a dry tap there, right? So Increased neoplastic proliferation of megakaryocytes are going to make a lot of, you know,
Platelet-derived growth
platelet-derived growth
factor.
factors, which are going to lead to fibrosis inside your bone marrow, right? So we are going to be having fibrosis. So two things can occur as a result of that. If you are having a lot of fibrosis, for example, if we have some, erythropoietic stem cell being there and they're just making red blood cells. So as you know, this area is fibrosed. So the red blood cells which are made there are going to squeeze through these small areas. And as they squeeze out, they will just end into something called teardrop cells, right? They would cry because there is very little space for these red blood cells to move out due to that extensive fibrosis. So we are going to be having teardrop red blood cells. So you can just clearly see it's a teardrop red blood cell, right? Because the red blood cells are squeezing through that fibrous area, very little space it's having, so it would end in a teardrop size. Is it clear? So it increases the risk of infection, thrombosis, and bleeding as well. Because if the fibrous component is replacing the entire hematopoietic stem cell, so it can lead to a lot of infections because you won't be having any cells to make granulocytes. You won't be having any cells to make the lymphoid lineage. So thrombosis as well because we can just replace that platelet cells as well. So that's the idea. Okay. So this was the entire thing about the chronic and the acute. We are going to go through it tomorrow. We are having our boot camp session. Okay. And in that bootcamp session, I'll be starting from first aid, reviewing from first aid, right? So we did pathoma. In bootcamp session, we'll be starting from first aid. So if you guys remember, we did platelets module from the pathoma plus first aid. So from tomorrow, I'll just start, the red blood cells module from first aid. So if we have some extra things there, we are going to cover it from there, okay? So next topic which we are going to discuss is lymphadenopathy. What is lymphadenopathy? Yes, you must read it from both, right? Like in first aid, it's written really in a disorganized way. You can never know, right? You can never know the classification. What is acute? What is chronic? This is, the way the pathoma have arranged everything. So that's the check.
Excuse me,
So
Dr. Ahmed. What
yes,
time
please.
of class tomorrow, boot camp?
Okay, so boot camp is going to be starting at the same time, right? Today we
10,
just
10
started.
a.m. EST?
Yes, but it's going to be prolonged session, right? So we'll be having 2 to 3 hours of session in order to finish those things. Okay. Okay. Hello.
Yeah, thank
Yes,
you.
doctor.
Okay. Perfect.
So what about the
So
pharmacology? We are still not finished the
yes.
pharmacology.
No, I'll just do the pharmacology tomorrow as well, right? So I'll just definitely take some time out for that. Okay. And I have some really interesting sketches as well to share with you guys. I have just compiled some other slides for certain topics as well. So tomorrow, and if the bootcamp does not finish tomorrow, so obviously we are going to give an extra day for that, right? So get prepared for your assessment on Monday, right? On Monday you are going to be having assessment, okay? Of this, okay. So let's
Okay.
discuss lymphadenopathy, right? What is lymphadenopathy? Of your lymph nodes. But we know that lymph nodes can get enlarged in two cases, right? For example, if you have any kind of infection going on, what would happen? The immune cells there in the lymph nodes are going to, they are going to grow more. For example, if you have bacterial infection, so the follicular region of the lymph node is going to enlarge. If you are having some viral infection, the parafollicular region would enlarge, right? So we know that lymphadenopathy can be seen in infections as well. But remember, in infections, the type of lymphadenopathy which is seen, that's going to be painful lymphadenopathy. So whenever in the question stem you see painful lymphadenopathy, that's due to infection. But if you have painless lymphadenopathy, that's more probably going to be due to a cancer, which we'll be discussing here, right? Painless and painful is going to tell you whether it's an infection going on or whether it's a cancer or chronic inflammation or a lymphadenitis, but mostly cancer, carcinoma going on, right? The metastatic carcinoma as well, whenever it metastasizes to lymph node, they would just enlarge, but there would be a painless enlargement. That's really important, okay? Is it clear? Hello?
Yes, sir.
Perfect. So Let's just discuss follicular hyperplasia. We know that, for example, whenever we have any kind of infection, the follicular region, the B cells are going to grow, which is going to give you follicular hyperplasia, right? Okay, let me just erase it first. Okay. Okay. So the lymphoma, we discussed that it's going to be due to lymphoid cells that's going to become a cancerous, right? So they're basically divided into two types: Hodgkin lymphomas, non-Hodgkin lymphomas. Simple, right? I'm going to make it really simple. Hodgkin lymphoma, non-Hodgkin lymphoma. Hodgkin lymphoma is the most common, 60%. Non-Hodgkin lymphoma occurs in 40% of cases. We are going to discuss what is non-Hodgkin lymphoma, what is Hodgkin lymphoma. Hodgkin lymphoma further is going to be divided on the base of cell type, B cells, T cells. But the B cells are really important. It's really rare to see non-Hodgkin lymphoma of T cells, right? So mostly we are going to do those B cell or non-Hodgkin lymphomas, right? Further, these can be divided on the basis of the like the size. We can have small B cell lymphoma, we can have intermediate size B cell lymphoma, we can have large B cell lymphoma. The way pathoma have reorganized these things, it's really best, right? Really great. Okay, so we discussed, we have non-Hodgkin lymphoma, we have Hodgkin lymphoma. Most common one is going to be non-Hodgkin lymphoma, 60% of cases. Okay. Further, it can be due to B cells or T cells, but T cells is really rare. You are only going to have B cells on your exam day, in your first aid, and everywhere, right? Further, they are classified on the basis of size: small size, intermediate size, large size. So let's discuss what does a small size B cell lymphoma includes. It includes follicular lymphoma, it includes mantle cell lymphoma, it includes marginal zone lymphoma. So let's first of all break these things down, right? We discussed what were the follicles, if you guys remember. I just told you that in the cortex of your lymph node, you're going to be having structure called as follicles in which the B cells are going to be sitting. We discussed we have two types of follicles, the primary follicles and the secondary follicles. In the primary, we are having dormant B cells. In the secondary, we are also called as germinal center activated B cells. The zone which is surrounding which is really close to this follicle, this zone is basically known as mantle zone. That area is known as mantle area, mantle zone, right? And the zone which is surrounding your mantle is known as marginal area in the lymph node. These are the names. So, what is follicular lymphoma? When we have cancer only limited to this follicular area. That's so simple. What is mantle cell lymphoma? If you have a cancer which spread through the mantle zone of lymph node. What is marginal zone lymphoma? If you have a cancer that is spreading to the marginal zone of your lymph node. That's all, right? So let's discuss these in little bit more detail. Okay. So we have follicular carcinoma, follicle F14, 14, 18. Okay. Keep that thing in mind. Let me just count, right? So it's neoplastic proliferation of B cells, non-Hodgkin lymphoma, mostly B cells. What's the cell surface receptor? We know that. That's CD20. Okay, follicular, it means they are going to lie in the follicles, right? In the follicles. And why do we have that? It's due to 14, 18 translocation. Remember one thing. This 14 chromosome is like really important to make that IgG heavy chain for your immunoglobulins, right? So that's always going to be present. What is 18 translocation? It means something from this chromosome 18 have come here to the 14. And as 14 is the normal chromosome for these B cells, in order to make IgG heavy chain, if something have attached itself to 14, so that thing is also going to be overexpressed if you are, translating this 14, right? So overexpression of something on 18 would just come there. And what's that? That's BCL2. If you guys remember in apoptosis, what is apoptosis basically? It's basically a programmed cell death. We are killing a cell. How was the apoptosis going on? We discussed we have mitochondria, and in the mitochondria we have cytochrome C, and we have a policeman there called as BCL2, which have okay, this is a prison. You can just simply imagine in the prison we have this prisoner cytochrome C, and we have a policeman. This policeman have the key for the prison, right? Okay. So if you do not have the policeman, We do not have the key, so cytochrome C would just come out in the cytosol. And it would just activate caspases and it would kill the cell. That's the one way how apoptosis can occur, right? How apoptosis can occur. It's basically going to be present more on chromosome number 18 BCL2. So whenever we have 18 to 14 translocation, that is the BCL2 component from 18 chromosome comes and it get attached with 14. So it means you are going to be having, if 14 is just making IgG heavy chain for itself, it's going to make a lot of BCL2 along this process, right? So a lot of BCL2 means that you have a lot of policemen which aren't allowing cytochrome C to leak out. It means we won't be having apoptosis. So if you do not have apoptosis of the cells, with time the cell would grow in number, it would lead to a cancer, right? Is it cleared? Hello?
Yes.
Hello?
Yes, doctor.
Okay. So we have 14, 18 translocation. BCL2 from 14 is going to come to chromosome 14. And as it comes, it's have overexpression of BCL2. We won't allow apoptosis to occur. And if you do not have apoptosis, what would happen? It is going to lead to cancerous condition, a lot of cells there, right? So treatment is reserved to a lot of, okay, so we are going to give rituximab. What is rituximab? It's basically anti-CD20 antibodies, right? And chemotherapy in order to kill those neoplastic B cells. Simple, okay? Okay, follicular lymphoma is distinguished from reactive follicular hyperplasia. Again, if we have a cancer, cancer is also going to lead to lymphadenopathy, and if you have any kind of bacterial infection, let's suppose, right, that's also going to lead to you know, follicular hyperplasia, right? If we need B cells in order to fight off that infection. So follicular, how to differentiate? Okay, in both of the cases, the folliculars are going to be enlarged. How to differentiate whether it's due to a bacterial infection or whether it's a cancer going on here, right? So first of all, you have to understand the architecture of the lymph. Architecture of that follicles are disrupted, it means it's a cancer. If the architecture aren't disrupted, it means it's a reactive hyperplasia due to any bacterial infection. The other thing is tangible bodies. What are tangible bodies? Let me just tell you that, right? So let's just go back into our concept from immunology, right? If you remember, I just told you that the B cells are going to make a lot of antibodies, right? Okay, the VD-J recombination. Remember, and it would just try to have a sequence which is highly specific for an antigen. So until it do not have that sequence, it would just keep making a lot of antibodies, combining that VDJ and random combinations. Remember, and as we just get that specific, antigen sequence, so only that those antibodies, those B cells are going to survive, while the other cells are going to be killed because we do not need them. Did you guys remember the concept from immunology? Hello, hello, hello.
Yes, doctor.
Yes, doctor.
Did you guys remember the concept from immunology? No. Okay. Remember, for example, if we have a bug, right? Okay, let's suppose I just gave you an example. If it have a code 1, 2, 3 code present on its surface, right? So the B cells are going to be having these genes, and they're going to have random combination. They're going to get 2, 1, 2, 2, 2, 1, 2, 3, 2, and like it's going to randomly keep on combining its genes unless it get 1, 2, 3. So this 1, 2, 3 antibody is going to be specific for that. So we only need these B cells which are making 1, 2, 3, and we are just going to kill the other one because we do not need them, right? So who are killing the other one? Macrophages are going to come. They are going to eat, right? Them in the lymph nodes because we do not need them. We needed 1, 2, 3, which we have got, right? So the tangible bodies are basically the macrophages, which are eating, the unwanted immunoglobulin sequence. That's for concept you guys can remember, right? So this kind of entire reaction occurs in which condition? In an infectious condition, right? If we have an infection, if we have an antigen, right? Hello?
Yes, sir.
It means that the tangible bodies are only going to be present in an infectious condition. Can I say that? In order to eat away all of the other B cells which we do not want, right? While in cancerous condition, you won't be having those tangible bodies. So the lack of tangible bodies or macrophages in the germinal center, secondary, everything is occurring in the secondary germinal center.
secondary follicles, right? While it's going to be present in an infectious condition, while lack of the tangible bodies are going to suggest that it can be due to you know cancers, right? BCL2 expression as well is only going to be present in the follicular. Basically, we are differentiating whether this enlargement of follicle is due to any cancer or whether it's due to a normal infection going on, right? So if you have BCL2 expression, it means that it's going to be due to cancer, follicular lymphoma. Monoclonality. What is monoclonality? We discussed monoclonal B cells and polyclonal B cell. Do you guys have any idea? Yes or no? Hello?
Yes,
Yes.
mono is single, poly is multiple.
Arising from single to
Yes,
multiple.
single specific B cells. Like for example, let me just give you an example. For example, if we have B cells in our body, some of them are, you know, let's suppose from Pakistan, some of them are from India, some of them are from America, right? So this entire colony is a mixture of different people. That's a polyclonal. They can make a lot of offspring of different variety, different diversity. They are polyclonal B cells. But if I only just take a one kind of B cell, let's suppose the Pakistani variant of that B cell, it's going to be a monoclonal. It can only make Pakistani children, right? So we are going to be having only specific kind of antibodies, right? Not so polyclonal is a single, you know, ancestor and multi or polyclonal is sorry for a multiple and a monoclonal is going to be for a single. So whenever we have a cancer, so that's obvious that we are going to have cancer in one of them, right? We cannot get cancer all at a time in all of these, these different variants of B cells. Either we can get cancer of this, of this, of this, right? So it's going to be monoclonal. If you just look for the cancer, so it would just consist of only the Pakistani B cells, right? So that's going to be a monoclonal proliferation, and that's going to be one of criteria for cancerous formation, and that makes sense as well, right? So if you have a mutation in a single, mutation is occur in a single cell which lead to cancer, right? So it means it would occur in a single specific population of B cell. Monoclonality is going to be seen, right? And follicular hyperplasia is going to be a polyclonal. All of this community is going to make antibodies. If you have different bugs, you need different antibodies. So whenever the entire colony is involved in making these antibodies, offspring to kill an infection, that's a polyclonal, monoclonal for cancers. That's all. Is it clear? Okay.
Yes, doctor.
Yes, sir.
Okay, perfect. So let's just come towards the mantle cell lymphoma. That's clear. It's a B cell lymphoma. Whenever it enter into the mantle zone, what was the mantle zone? Surrounding your follicle is mantle and then your marginal zone, right? So neoplastic proliferation of B cells once spread to the mantle zone, it's a mantle, you know. So the mantle is going to be due to 11-14 translocation, 11-14 translocation, right? And it's going to be due to cyclin D. Cyclin D. So what happens if you have cyclin D coming from 11 to 14? 14 is the normal one making IgG heavy chains. We know that. So once the cyclin D come there, it would increase, it would move the cells from G1 phase into S phase. S phase is for the synthesis phase. We are synthesizing a lot of cells now by getting cyclin D there. Synthesizing a lot of cells with time won't lead to cancer. Yes, it would lead to cancer, right? So G1 phase to S phase to the synthesis phase is going to be synthesizing a lot of cells. Synthesizing a lot of cells with time is going to lead to cancer formation. So mental cell lymphoma B cell, whenever it's spread to the mental area, right? As it's spread to the mental area, we are going to be having cyclin D overexpression. So again, the story is same. From the 11th chromosome, cyclin D is going to be stuck into 14. So as 14 is making its, IgG heavy chain for itself, so cyclin D or overexpression is going to be seen. Overexpression of cyclin D is going to push the cells into the synthesis phase. And as you are pushing a lot of cells into the synthesis phase, you are going to be having a lot of synthesis. A lot of synthesis is your cancer. Simple, right? Okay. So let's just come towards marginal cell lymphoma. What is marginal cell lymphoma? Margin. It's at the end portion, right? The end portion of around your follicle is margin, right? So for the margin, in order to get into the margin, you have to travel a lot, right? Hello? For example, if your follicle mental and margin, right? So for example, if I want to get into the marginal area, so I have to travel a lot, right? And a lot of travel is going to take a lot of time. So can I say that it would just take a chronic time for me to travel to that area, right? To the marginal area because it's really far away. So remember, chronic time, a lot of time. So it's going to be associated with chronic conditions. Chronic condition, really important. So anyone having chronic inflammation, for example, Hashimoto thyroiditis, Sjogren's syndrome, H. pylori gastritis, are going to get this marginal zone lymphoma. B cells are going to take a lot of time to travel to the margin, a chronic period of time seen in chronic conditions, right? Like Hashimoto's thyroiditis, Sjogren, and H. pylori gastritis, right? Okay, maltoma. What is maltoma? Yes, mucosa associated lymphoid tissueoma. What is mucosa associated lymphoid tissue? Pyre patches are malt, right? That are mucosa associated lymphoid tissue. Pyre patches, remember? They are lymph nodes, same as lymph node. It means they'll be having all of these features as lymph nodes, right? So if we have H. pylori, so we are going to have maltoma because H. pylori in the mucus, and the more near one to the mucus are going to be your, these fire patches, right? So we are going to have maltoma there. Is it clear?
Yes.
Okay. The other one is Burke 8 lymphoma. Burke 8 lymphoma, not Burkitt, right? Burke 8 lymphoma. Okay. So in Burkitt lymphoma, Burke 8 lymphoma, what we are going to see again, okay, we discussed all of the small variants, right? Now let's come toward the intermediate size B cell non-Hodgkin lymphoma. If you guys remember, right? We discussed non-Hodgkin lymphoma can be B cell. B cell can be small, intermediate, large. In the small one, we can have follicle 14, 18. We can have mental is mental, right? 11 cyclin D. Okay, a mental guy just riding a bicycle. Okay, then we can have marginal. We have to travel chronically to get into the margin. Again, it's a B cell. So we can have, okay, these were the small cells. So let's come to intermediate size. Is Burke 8, right? So in Burke 8 lymphoma, we are going to be, that's an intermediate B size lymphoma, we know, and it's associated with EBV, really important, right? EBV virus. It can lead to Burkitt lymphoma. So we can have two variants of it, an African variant and a sporadic variant. Okay, so we can see an African form, which is going to appear at jaw, mass at jaw. This is going to be exact same picture from your viewer. They're going to tell you what's going on here. That's the Burkitt lymphoma, which translocation. So let's just do that, right? So, and a sporadic form which would just occur in abdomen or somewhere else, not at the jaw, right? So it was Burke 8 lymphoma. In Burke 8 lymphoma, we have 814 translocation. The idea is really same. Again, something from the 8 is going to enter into 14, and as 14 is making, IgG heavy chain for itself, something from the 8 is going to be overexpressed. And what's that? That's c-MYC. So if we have a lot of c-MYC, what happens? c-MYC promotes cell growth. So if I'm promoting cell growth, a lot of cell growth, so what would happen as a result of that? We're going to have a cancer. One thing which I just missed and really important is about follicular lymphoma is that follicular lymphoma would always occur in waxing and waning pattern. Really important. In your UWorld MCQ, they're just telling you an individual appear with painless lymphoma. After some time, there was no problem. Or once again, he just come to you again, he was having that painless mass. What's your diagnosis? That's going to be follicular lymphoma because they're occurring a waxing and waning phase. Okay. So whenever we have c-MYC, a lot of
Doctor,
c-MYC,
it is always painless.
yes, mostly it's going to be painless. Cancers are painless. Cancer are painless, right?
Okay.
Okay. Okay. So 814 c-MYC. What would c-MYC do? It would promote the cells to go into the growth stage. If I'm growing a lot of cells, it means I can get cancer in the end, right? So we can have like starry sky appearance, which would just indicates a high mitotic index. Cancerous cells have high mitotic index, right? So that was all about intermediate. The last one was large B cell lymphoma. So in the large B cell lymphoma, it's going to be again the proliferation of B cells, okay, that grow diffusely in sheets. Most common form of non-Hodgkin lymphoma are the large, right? So clinically aggressive, they're really aggressive. So these are some information which you have to keep in your brain, okay, simple. So arises sporadically, then it is going to transform into low-grade lymphoma, right? So it will, okay, and present in late adulthood as enlarging mass and extranodal mass. So this is pure information which you have to read and Just keep in mind, right? So this bucket is really important, and I bet that you are gonna have an MCQ in your real exam from this bucket. Okay, you are gonna have MCQs from this follicular lymphoma. Okay, just keep that in mind. And mainly they are going to ask you this translocation 11, 14, you know, this 14, 18, 8, 14. Those are the main thing which you guys have to keep in mind, right? Is it clear? Okay.
Yes.
So we have
Yes.
two topics remaining, and since the time is finished, so tomorrow I'm going to start boot camp with you guys, in which we are going to finish these things. We are going to give some time for the pharmacology. Then we are going to revise entire things from our first year. So there's going to be the plan for tomorrow. And yes, any questions?
Um, yes, Doc. So we still have the RBC lecture missing.
In the recordings?
Yeah, we didn't get the link for the recording.
I
The
think
second
I,
lecture that you took for RBC, I think it was the normocytic anemias.
okay. I think I uploaded that, but if no, so I'll just look into that and I'll just upload it. Okay.
Okay, thank you.
Thank you so much.
Dr. Ahmed, did you cover plasma cell disorder?
Which cell disorder?
Plasma cell disorders?
Plasma cell disorder is going to be a topic for tomorrow, as I mentioned.
Okay,
We're going to
thank
start with Hodgkin lymphoma, and then plasma cell disorder is really important, believe me, right?
Okay,
So
thank you.
that's going to be a topic for tomorrow. Okay. Thank you so much. Hope so you guys enjoyed. Thank you.
Thank
Have a
you.
nice
Good day.
day. Bye.
Thank you, doctor.
Thank you, doctor. Thank you.